Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirrahmanirrahim. Wassalatu wassalamu ala Mohamed. Yang terhormat Prof. Fasli, selaku Rektor Universitas Yarsi, Prof. Rika, Dekan FK Yarsi, Wakil Rektor 2, Dr. Yulia, dan juga semua rekan dosen dan mahasiswa yang hadir. Oh, juga dengan Wakil Rektor 5. Terima kasih atas kehadirannya semua. Sore ini kita insya Allah akan bertukar pikiran. We're going to have interesting talk. We're going to listen to interesting talk by our guests from University of Nottingham. And I personally know two of them because they visited Indonesia a couple of years back. And now there are more of them coming from Nottingham. More and more coming, yes. Not just COVID, but also the Nottingham invasion. Okay, so before we going to listen to our guests, please join me to hear from Prof. Fasli. Prof. Fasli is going to give some remarks about the session today. Prof. Fasli, please.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. To our distinguished guests, Professor Mohamed Elias, thank you for coming back, Professor Elias, and Dr. Abik Kerji, and Professor Shilaj Raman, and also Professor Kevin Gaston. And we have quite significant audience from YRC, all of the graduate student and also the vice rector and also dean of the related faculty coming to this very important seminar. In short, I would like to welcome you all and really appreciate your willingness to come to Indonesia, long away from UK, in the middle of COVID, so this is really a surprise to us and we appreciate it very much. And second, we see we are not more ready to have better and more cooperation in many aspects. We have just developed Artificial Intelligence Center. We start already with ICU, and we mine data from all patients through ICU. And tonight we will have the director of hospital join us for our dinner to discuss more detail about what is possibility in mining the all potential data from hospital. And we have quite strong with Prof. Rika leadership on genomic. And we also dream of the Indonesia still one of the biggest contributor to the TB patient in the world, number 3, and soon maybe becoming number 2. Which is worried us a lot and worry the world a lot. So how can the precision medicine can also be addressed in this regard? And we would like to have more profile who are being affected, who are lead to worse outcome and who can lead to better outcome. So all kind of this becoming question to us, and we would like to welcome you if you want to join us in this endeavor. And then lastly, we are always thinking about how can we bridge the all activities, research and pilot and model and whatever product from the cellular level to be used at clinical stage in the hospital, and then how can this being transferred into the community at large. So we have many localities, local government being partnered with us very thoroughly. We can go to every household, getting data from household level, not only physical data, but also blood and also all kind of data. And then we are questioning ourselves, how can we also mine this potential? Patient coming for the cellular examination, but broadening the variable that can be collected, coming to the hospital for the examination or for the therapy. How can we get data from cellular level, but also related to the community? And if we go to the community, how can we also can bring back the relevance to clinical setting and then also to the cellular activities. So again, thank you very much for all of you. Let's big applause to Profesor Elias, Prof Gaston, Prof Sheila, and Dr. Abik. And terima kasih pada Dr. Wilia dan juga Dr. Ahmad Rusdan for arranging this very important meeting. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Jazakallah khairan kasiran, Prof, atas remarknya, Prof Asli. Now, the next speaker, I need to introduce you this time, is Bu Santi. So who is Bu Santi? Okay.
Sorry, Bu Santi, because Bu Santi like welcome to my side. She is a big part of us more than
That's right. So that's why the importance of personal connection, because when it comes to connection, it comes with trust. When it comes with trust, we have collaboration. And we would like to hear from Bu Santi to introduce NICRAT. So NICRAT is a program that is meant to increase the collaboration between University of Nottingham and cancer research and also studies in Indonesia. So how it's going to come to be, what's the history a little bit. So Bu Santi is going to tell us all about it. And Bu Santi is a good example of diaspora, Indonesian diaspora. Okay, so she's trained in the UK, but she doesn't forget her roots. Yeah, from Banyumas. Yeah. So you will hear her medok things, you know, a little bit. Bu Santi, please.
Assalamualaikum warahmatullahi wabarakatuh. Terima kasih Bapak Ibu atas hadirannya dan terutama buat Prof Asli who always welcome me like being back to my home here in YRC, and obviously to all my colleagues here in YRC, Pak Ahmad, Dr. Yulia, and now I know Prof Rika as well. Yeah, so delighted that you are happy to hosting us, and this time I can bring along lots of experts from University of Nottingham as part of the Nottingham Center for Cancer Sciences, and hopefully we will develop more collaboration with University of YRC. So I won't be long. I just want to give you a snapshot where we're coming from. With regard to our Indonesia collaboration. So we established Nottingham Indonesia Collaboration for Clinical Research on Training, or NICRAT, in 2019 with Professor Mohamed Elias to foster many of our activity between University of Nottingham and some of the partners in Indonesia, including Universitas YRC. Next, please. So we gladly managed to secure some pump priming grant that enable us to kick off the program, including Newton Fund with University of Gadjah Mada. And then we have IDB as well for the translational and innovation project of commercialization for colorectal cancer diagnostic kit. And then we also involved in COVID-19 research at the time with LIPI, now become BRIN, obviously. Next, please. Yeah, we are very grateful for all the support that been given to us from many people and partners, including BRIN, Yayasan Kanker Indonesia, YRC, obviously, and then also from Indonesia Embassy in London. Next, please. So we start in our engagement through the research in colorectal cancer, because we see that cancer is still major health burden in Indonesia, not only in terms of health, but also in terms of economy burden for BPJS who director we're going to meet hopefully in dinner later. So, and we also observe a particular interesting fact in Indonesia, where our patients of colorectal cancer are much younger than and more in terms of number compared to what we found in UK, US, and Europe. So that's our starting point. So we start investigating the carcinogenesis of young patients in colorectal cancer, including in Indonesia. Next, please. But that's just our starting point. So basically our direction is toward precision medicine, like what Prof. Fazli just mentioned. So obviously we know that Indonesia is huge in terms of ethnicity and population, like Prof. Rika research has already tapping onto. So we have 300 different ethnicity, and who knows how this will affect the treatment of disease. And to do that, we need to do more research and hopefully come up with important clinical intervention. And this not only about biology, but also bioinformatics, artificial intelligence, and computer science, and many more. So that's the area that we love to pursue forward. Next, please. We are lucky to have several collaborators in Indonesia. We have obviously BRIN, Gajah Mada, Yarsi, Universitas Indonesia, Riau, Muhammadiyah as well, Bio Farma, Dharma East, and so on. So I'm a firm believer of collaboration, and I think we can really make an impact if we collaborate. Next, please. This is just the snapshot of activity that we have done so far through excellent program that Prof. Elias and Dr. Abik deliver every year for like in molecular diagnostic, image analysis, and histopathology training school. We are able to open the course for our colleague in Indonesia. So far, we already have around 300 Indonesian medical doctor and researcher participate in our courses. And obviously, there's many more engagement that we have done. Next, please. We publish with our partners as well. So we have with UJU, GM, and with LIPI in COVID and colorectal cancer. So just want to highlight that we also care about our science. Next, please. And then obviously you all know I founded the startup PatGen that currently being incubated in BRIN Cibinong, basically working on bringing low cost or affordable molecular tests for diseases, especially cancer, for clinical implementation in Indonesia. Next, please. This is just our portfolio of PatGen product. Next, please. I just skip this. Yeah, next. We're just proud about this kind of ecosystem that we are building. So not only we work with ministry and funder or public policymaker, but also strong collaboration with university as well as with industry. We have obviously PatGen, but we also work with Biopharma, and then Biogen is the one that going to support us in the HPV slide scanning, Pak Ahmad, from Malaysia, and then Evidential in Netherlands. Next, please. This is kind of the direction that we already partly discussed. There's capacity building, research, and obviously health innovation and clinical implementation of the technology. And then there would be a potential grant that we can apply together. I think that's it. Next one is just, yeah, thank you for your support, and then hope to collaborate more. Thank you very much. And you, next please. We're waiting for you all in the UK, in Nottingham. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Ibu Santi. Hopefully there will be a more collaboration coming up, especially with the grant application, and get accepted, inshallah. Okay. All right. So we have a very nice lineup of speakers today, and I'm very happy that many students, graduate students, actually joining us here and also in Zoom. So the first speaker from University of Nottingham is Professor Kevin Gaston. I hope I pronounced it right. Okay, so the Prof. Gaston is a professor of cancer sciences, co-director Center for Cancer Sciences, Faculty of Medicine and Health Science, University of Nottingham. He's going to talk to us about University of Nottingham Cancer Sciences and BSc of Cancer Science. This is interesting because in YARC we have this graduate school in master degree and doctoral degree, and we also plan to have the undergraduate in biomedical science. So I think it's important for us to learn how Prof. Gaston is going to set up this BSc, Bachelor of Science in Cancer Sciences. Prof. Gaston?
Hello, everybody. Thank you for the very kind introduction. It's lovely to be here. We're enjoying our trip very much so far. And I've already been introduced, so I won't say anything further. Today, I'll tell you a little bit about Nottingham University, just very shortly. And then I'll tell you about our Cancer Center, and then a little bit about the course that we're developing. And then hopefully there'll be some things that we can teach each other about how to develop these new courses. So just a few words about Nottingham University, for those of you who don't know. Nottingham, like Indonesia, we are an archipelago, and this is the main island, and Nottingham is right in the middle of the main island. So we're a bit stuck right in the middle. We're about 3 hours from London by car. We're a member of the Russell Group of leading universities in the UK. There's of all the universities, there's a small group called the Russell Group, which are the most prestigious. We're a fairly big university. We have 25,000 students and 9,000 postgraduate students and around 3,000 researchers. And in terms of the rankings, if you believe those kinds of things, we're ranked about 7th in the UK for our research, and we're in just outside the top 100 universities in the world. So thank you. Our Center for Cancer Sciences is part of that university profile. And it's supported by recent funding from the university to build a center that would integrate our cancer research across the university, but wider than that, and going to the hospitals that are associated with the university. And so the center is a home for cancer research across the whole university. It's headed by Professor Dave Bates and a team of co-directors. I'm one of the co-directors, and Professor J. Raman here is another of the co-directors of that center. We have a brand new building that was opened just a few years ago, and we have some very good facilities for research. And as part of this expansion of cancer sciences, we've created this new undergraduate courses in cancer biology. And we're the first university in the world to start undergraduate courses in cancer biology or cancer sciences. The way the center operates is to try and integrate all of the cancer research that's going on across the region. So the Center for Cancer Sciences acts as a hub to try and bring people together. Many of them work in the hospitals. So associated with Nottingham University, we have 3 hospitals: Nottingham City Hospital, Queen's Medical Center, and the Royal Derby Hospital. And these are on 3 different sites. So it's important that they have some kind of interaction and collaboration. And that is coordinated by the Center for Cancer Sciences. But we also have basic researchers who are working on University Park, which is the main university campus. And then we also have other aspects that are linked into cancer sciences, like our clinical trials unit, which can do clinical trials, and university spin-out companies that are commercializing some of our research outputs. As part, oh, sorry, just one second before we go on. As part of the center as well, we also have 2 specialist centers for cancer at the university. We have a children's brain cancer center and a breast cancer center. And we're hoping to develop additional centers in the future. Next, please. The idea of the center is to coordinate this large effort because there's a lot of different groups. We have 70 different academic research groups scattered across 12 schools and 4 faculties. So we need this center to bring everything together and to create a cohesive whole. the job of the center is to, and all of these different researchers, is to take our fundamental research through into applications that make benefit for patients. So this process is, Sheila will talk about it in more detail later, but it begins with our fundamental research, which is then feeds into our applied research, and then eventually through into clinical research, linking all of these things together. Next, please. Underlying that, we have our research, our technical basis, which is in cell and molecular biology, genomics, patient samples, and clinical trials. And these things all cross-fertilize to make this pathway work. Next, please. This just shows some of the areas in which we specialize, but it's our main specializations, but not all of them. And we have research groups in these different categories. And next, please. As part of this center, what we have to do is we have to try and make an integrated educational pathway that takes students all the way through this whole process. And the bit that was missing from this was the first part, undergraduate training. Because in cancer sciences and cancer biology in general, we all know that there's been in the past postgraduate training, like master's courses and PhDs, and also postdoctoral training, and also academic groups. But what was missing was the first part, undergraduate programs. Typically, undergraduate programs would be biomedical sciences or some other kind of, or medicine perhaps, that would then feed into this pathway. And we decided to take a different approach and create undergraduate courses in cancer sciences. Next, please. And why did we do this? Why did we go to the bother of setting up this new course? Well, the reason we did it was because our collaborators in industry were telling us that there was a shortage of highly skilled labor in this area. So there's a lot of different career opportunities within cancer sciences and biomedical sciences in general. But why are we not training the people in this area, specializing in cancer right from the beginning? The different career opportunities are shown here. Everything from research, that's one of the main ones, obviously, but also data processing, as we've just heard about. All this data that is being collected needs to be analyzed, and we're lacking the power of personnel to do that analysis. So we need to train more people in this area. We also have new ways of detecting cancer that weren't available a few years ago. And again, we need highly skilled personnel in that area. Clinical trials management is another area. Then once products are produced, we need sales and marketing. We need to be able to get those products into the hospitals. Also, another area that we need to look at is advocating policy change, because I'm sure it's the same in this country too, as it is in the UK. All of the important decisions are made by politicians, and we have to communicate with the politicians and tell them what are the priorities for medical applications. And then finally, commercialization of this work. We need to be able to talk to venture capitalists to build the kind of companies and infrastructure that would then promote cancer biology. Next. So our collaborators in industry were saying, why aren't you training people in this area? And students were saying to us as well, why can't we learn about cancer biology? Why do we have to wait to year 3 of our biomedical sciences course before you teach us anything interesting? And we thought, well, let's turn everything around and put the interesting stuff, the cancer biology, right at the beginning of the program. And that's what our cancer sciences programs do. So we define cancer sciences as being the science that underpins cancer. And that includes everything from the fundamental research that people like I do, and also through the drug discovery and patient care, as our clinicians do. So it covers everything. And we try and cover that in our degree program. So basically it's a biomedical sciences degree, but the difference is that we specialize in cancer right from the very beginning, right from day one. And we're the only course in the world that does this. We're research intensive and we're led by clinicians as well. So we have a lot of clinicians involved in the delivery of the program, such as Professor Elias, who's going to talk later. And as I mentioned, we're the only degree that's like this so far in the world. So this was a big risk for the university, because we were starting a program, but not knowing whether students would come to do it, or whether they would say, this is a new thing, why should we do this? Luckily for all of us, it's worked, because we started the program in 2019 with 21 students. The year after that, we recruited 40 students. And the year after that, we recruited 57 students. This year, so far, we have about 330 applications. So the course is proven to be a success, and that generates lots of interest and obviously income for the university. So the university is happy with us. Next slide, please. Just to tell you a little bit about the structure of the course and what makes it different, what makes it interesting as far as the students are concerned. The difference really comes down to where we put the cancer biology. We put the cancer biology in year one. So in our year one of our program, we have hallmarks of cancer and causes and consequences of cancer, which are new modules that we've put together to teach cancer biology. And it starts right from the beginning of the program. Of course, we also have to teach the students about biomedical sciences. So we have to understand all the biomedical sciences that underpin what we're teaching them about cancer. So they have to learn about genes, molecules, and cells and human physiology as well. And that helps to broaden their education and make them good graduates. Next, please. In year two, we go into more detail about different types of cancer, and we use the different cancer types as a way of interesting the students and then telling them about a particular area of biology. So for example, we have a module on lung cancer and breast cancer, and in that module, we teach them about growth factors and hormones. So we use the cancer as a way in to teach the biology. Instead of teaching the biology first in the traditional program and then eventually getting to the cancer, we teach them about the cancer and at the same time tell them about the biology. And we do that for various different areas in year two. And then next slide, please. In year three, we have a research project. So the students do a research project working in one of our research labs. And also they choose more highly specialist programs, more highly specialist modules. At present, we have 4 specialist modules in year 3, but we're developing more of these modules. So eventually we'll have at least 10 modules in year 3 that will specialize in different areas and allow the students to choose what they want to specialize in. Next slide, please. Because it's a new program, we could make lots of innovations. So we have 16 new modules and we teach in different ways as well. All of our modules include interactive learning. So they're all sessions where we flip the teaching and the students go away and learn something and then tell us about it and we give them feedback. So it's not based on traditional lectures, it's based on interactivity with the students, which I think is a really good thing. We also have lots of speakers from outside of the university, speakers from industry and from other areas. And we bring the patient right into the course as well. So we have a patient-centered library project in year 2 and a patient portfolio in year 3, where the students follow the course of treatment for a particular type of cancer and also for a particular patient. It's anonymized, of course, but then they learn about how cancer patients are treated and how cancer research works and how cancer research is translated into the clinic. Next slide, please. So I'll give you one example of the kind of stuff we do. And this is why it's surprising, I think, because in year 1, we teach them about the hallmarks of cancer. From their first day in the university, we start teaching them about the hallmarks of cancer. And this really gets the students engaged and learning in a good way. So hallmarks of cancer it's delivered as lectures, practical classes, and then workshops. And it's the workshops that allow this interactive teaching. Next slide, please. And in the hallmarks of cancer, we cover topics that would normally not be covered until year 3 of a biomedical sciences program. But again, it works really well. Obviously, we have to teach at a year 1 level in year 1. So we have to simplify everything and make sure that it's appropriate for the students, but we can eventually go into more detail in year 2 and year 3. Next slide, please. So that's all I have to say, and thank you for your attention. And if anybody's got any questions, I'll be very happy to answer them.
Saya baru aja bilang ke Prof Fasli, itu materi tadi itu S2, sekarang akan jadikan S1 ya, determining jadi catatan. So thank you, Prof Gaston. I just said that it's a material for the master degree, but now we're going to move it earlier to the undergraduate program. So we're going to save the questions, so keep your questions until the end. We're going to have a QA at the end. So we're going to listen to all 4 of our guests. So the next speaker will be Prof. Abik Mukherjee. He is a good friend of ours. He's trained as a pathologist. He's going to talk about innovative teaching. And as you know, with all COVID going on, so we need to find ways how to get the point across in these different ways. So Prof. Abik, please.
Yes. Thank you, Ahmad, for that kind introduction. Prof. I'm very pleased to be here after a gap of 2.5 years due to the COVID break. And I know Yasi has got a very strong medicine program, and we've got Prof. Rika with us today from the Dean of Medicine. So it's a privilege to share with you our ideas about innovative teaching on undergraduate and postgraduate medical programs. So this is, so we talked about the BSc Cancer Sciences, but this is more directed to the medicine programs, and to just show you how the two programs cross-fertilize each other and feed into each other at Nottingham. So next slide, please. So as we all know that medicine programs all over the world are one of the most intensest of programs, because it has got a clinical rigor, it has got an academic rigor, which has to be balanced to the needs of the population base and the service that which comes with medicine. And I'm going to talk about the need for innovation, how that paradigm is shifting in medicine, and what we have to do thinking about the future, and use some exemplars from the University of Nottingham's medicine course, the MBBS course, and which is also provided by the Nottingham University Hospitals Consortium in Nottingham, Clinical QMC, City Hospital, Royal Derby, and we've now got the Lincoln Medical School, which is the new site, which is the new medical school to accommodate more medical students in the program. Next slide, please. So as we know, medicine is broad in scope, it's very academic, and I've talked about the academic and clinical skills, but it also comes with imparting the very soft skills we require of doctors, the good communication, the good team working, the good leadership, which is becoming more and more important in today's world, and also the implications of ethics and governance in not only clinical practice, as well as the clinical research that's coming in. The ethics and governance is becoming more and more important. Next slide, please. So, why do we need this innovation? We need the innovation because medicine itself is becoming more and more complex as we discover more and more. We know more and more, and the students want to know more and more. So we have to fit in a lot of complexity into still that time frame of 5.5 years in which the students have to be doctors for tomorrow. So the time frame has remained unchanged, but knowledge has increased in complexity. And with the knowledge expansion has come technological advances, which students want to know, and they have to know because they are doctors of tomorrow. And students are these needs are being driven a lot by the students as well as the patients we face in the clinic. And that is why we need the innovation. Next slide, please. And what I have observed in, so we as histopathologists and early years trainers and being involved in the clinical phase training programs have observed over the years that there have been some paradigm shifts in medical education in the UK as well as in Nottingham. And as we know, the medicine programs usually they work along the first 2.5 years is usually the preclinical phases, where a lot of the clinical background knowledge, anatomy, physiology, biochemistry, pathology, pharmacology is fed into the students, and then they go into the wards and see their practical utilization. But what has changed in the current medical programs is even a shift in this very early preclinical years from an academic textbook orientation to more a practical application of these facilities and faculties which we have. And the clinical phase was always traditionally very ward-based. But now the demands of medicine is interdisciplinary. We have to cross-talk with each other and learn to react to each other. And therefore, it becomes more interdisciplinary in the modern context. Community. So Prof was mentioning about the GP practices and how the community education is coming into clinical practice. And that has changed the complexity of education from just a hospital context to bringing in the GP and community programs. And we in Nottingham have embedded that in the medicine program. There are new population needs. With the increasing complexities of life, we now recognize that mental health is a big aspect of medicine. And while this was very marginalized in previous curriculums, one of the things which Nottingham has done has put forward the mental health aspect forward in clinical phases and has embedded it into the undergraduate program for delivery. So that's another important change that has happened. And technology has revolutionized, and we have seen this more during the COVID crisis, how technology-driven teaching has taken over medical teaching programs. Next, please. Soft skills. We talk about leadership, communication, team building exercises, and somehow doctors were previously expected to somehow metamorphose into these wonderful leaders, team building creatures, etc. But now these are now embedded in the medical program at Nottingham as directed competencies. They have to prove themselves throughout their 5 years in short little bits that they do, that they actually learn how to do it. Research. Clinical research is more and more a part and parcel of medicine. And we do not want our doctors to be left behind or to grow up in silo, because they need to understand a bit of research and they need to be able to interact with the biomedical partners to take translational research forward. So the integration of research has become more well-defined. Special study modules I'll talk about, and I'll talk about assessments as well, which has changed in complexion in Nottingham. So let's move on. So I'm now going to use some exemplars from the University of Nottingham's teaching program to highlight some of these points which I've highlighted. So we still have the two phases, the early years and the clinical phases, which were previously used to work in silo. Next, please. But Nottingham has done something with the social aspect of education as well. We've got the traditional entry medicine, so you go through your schooling, then you do your +2, and then you apply for the entrance exams or whatever, and you qualify for medical school. That's the traditional entry route. But people come from different socioeconomic backgrounds. So Nottingham has introduced something called medicine with a foundation year for those who come from a disadvantaged background. And they may not hit the grades exactly for a traditional entry medicine. But if they come from those backgrounds, with the help of a foundation year, they are being groomed to follow that medicine route. So that's an important social change which has happened with the medicine program. The other thing is, several people at this stage don't think about doing medicine or may have missed the bus just by missing out on the grades. But the brightest of them, or the very interested ones of them, may still want to come into medicine at a later stage. And we have made the provisions of graduate entry medicine so they can do a science degree, and if they want to, they can integrate back and come to a more condensed course in medicine to follow that pathway. And University of Nottingham provides that. Next, please. So the early years, which just used to be preclinical knowledge before, has now combined with it clinical skills. And this has been achieved by innovations in the curriculum delivery as well as in assessments. And in the early years, what we have as an integral part of the course, the MBBS course, every medical school student has to do a 3-month research project. And therefore, we give them a BMed Sci at the end of their preclinical with the research skills together, which is an incentive for them that they get a degree, but they also do a bit of hands-on research to integrate well. Next, please. So what the taught curriculum has changed is we've got so it still has the anatomical dissection component, but what we've added on is the clinical examination basics of each system. So when they are learning the anatomy at the same time, for example, they are learning the anatomy of the abdomen, at the same time in the same week, they are learning how to examine, how to palpate the liver, how to palpate the spleen on simulated models, etc. At the same time, they are learning about the main cancers in the system in the lectures at scheduled times, along with the radiology and the pharmacology of the system. So it comes not only that anatomy is being taught for 3 months or physiology for 3 months, it's an interdisciplinary approach from day 1 in the week. That's how the course is run, and it's now assessed by MCQs, as well as, next slide, please. So at the end of year 2 and the beginning of year 3, they do that BMed Sci project, and to which we contribute as academicians. Sheila, Kevin, and all the researchers, they contribute little projects, and they do laboratory-based research for 3 months. They can also opt to do clinical research. They can do systematic reviews, meta-analysis, and get supervised for that, or they can get involved in clinical audits. But more and more, the emphasis is on doing a laboratory project at that stage. And that is assessed, again, through multiple channels, poster discussion, dissertation, and viva. So it's quite rigorous in that process. Next, please. When we move on to the clinical phases, previously we were just taught in the wards, yes? And they've stayed for 3 months on a surgical ward, 3 months on a medicine ward, but that has changed as well. And students are put into their practices at either hospitals or GP surgeries, and it's again all parallel interdisciplinary learning. It becomes problem-based. Information technology has transformed what you can do as podcasts, what you can do as summative and formative assessments, etc. And consultation skills are taught online as well. Next, please. So how would that interdisciplinary week run in the clinical phase? So in the clinical placement in a ward for a specialty, they, for example, they are put on a certain specialty, say GI for that week. At the same time, an online case of the week is released. And we, from the various other faculties which were there in the preclinical years, we provide them supplementary tutorials along with their wards of the pathology, clinical chemistry, radiology, and pharmacology. So it remains an interdisciplinary approach throughout, so that when in real life they come and face the multidisciplinary team discussion, they are well equipped. Next, please. Just to give you an example, in the ward, they see a breast cancer patient, they discuss their differentials. I go in on the pathology and would probably say, why do you see the dimpling of the skin or the inversion of the nipple? What's the mechanism behind it, so that they understand that the dimpling of the skin is due to the tearing of the lymphatics. They can go back to the clinic and understand that when we ask the patient to put their hands on their hips, we are actually testing for the fixity on the muscle. So it all relates together. They learn to look at the mammogram of the radiology in the same week, and then they learn about the staging and the molecular at the same time in the same week. So it all comes together from various parts to understand how that concepts can be grilled into medical students. Next, please. Specialization at undergraduate levels is often not possible, but University of Nottingham has thought about specialization at undergraduate levels. And so they've made a provision of 200 special study modules, which run for 6 to 8 weeks in the clinical phase, and they stay in these departments for 6 to 8 weeks. They observe, they write reflections, they write an essay, and they have a viva and are assessed. Next, please. And just to give you an example, I can't give you the list of all. So as I said, mental health is huge, and look at the different stuff which is offered: forensic psychiatry, early interventions in psychosis, offender mental health, old age psychiatry. So a variety of programs where people might be really interested in niche areas, in obs and gynae, the cancers in gynae, or just assessing fetal movement, somebody who's more interested in the obstetric part. Next, please. But also in soft skills modules. For example, in leadership, they can do developing people, coaching, mentoring, and leadership type of programs. They can understand how education works with the health education, medical England fellowship experiences, or something in medical education, very core, very niche. If they want to become a medical educator themselves, what do they do? And there are so many of these different modules around. Next, please. So that was about the undergraduate program. If I shift now to the postgraduate program, where people are specializing. So how specialisms work in the UK is that each discipline has its own Royal College, and the General Medical Council and the Royal College have directives and a training program which each of the hospitals have to provide in each of the specialisms, for example, medicine, surgery, histopathology, psychiatry, etc. So we encourage the specialisms, and the novel assessments which have come into the specialisms is not only they have got their summative assessment in terms of competency-based OSCEs, etc., but throughout the year, they have to show by discussion of cases, by actually doing the cases on the wards on a day-to-day basis, or for example, taking up a leadership role in the department, delivering a teaching program in the department. So all of that has been embedded into the postgraduate program. We have integrated technology. For example, Prof is going to talk about digital pathology. That has now been embedded. So we are now moving on, if we can move the whole FRC Path exam one day to be online, and daily reporting to an online, so we can communicate with each other on a telepathology basis. Next, please. We had a few of your trainees who were doing doctoral training programs coming out of medicine. In the UK, the postgraduate academic training program is absolutely clearly laid out now by NIHR and has been adopted by the University of Nottingham. So we've got the academic clinical training programs in which the more junior specialists, they can take about 9 months out during their specialty to do a training program in academia of their choice, build on that, to build on a research grant, and that they follow on with a PhD in that. Or after doing the PhD, while still doing their clinical training, they can still maintain their research facilities and go for a lecturership and try to become PIs of tomorrow, developing niche areas for themselves. Next, please. We take great pride in providing postgraduate training and teaching courses. And I can say from the histopathology point of view, these are various courses that we provide at Nottingham, the Molecular Diagnostics Training School and the Image Analysis Training School, which a few of you may have attended already. We have the Transforming the Knowledge Landscape initiatives. For example, if you want the wider group of clinicians, the older group of clinicians who do not know much of the genomic language, etc., you can do crash courses to go out and start those communications. We can do master classes in various areas like the GI Masterclass and the FRC Path training. And these can all be either online or face-to-face, as we've seen during COVID times. And we propose to blend and move forward in a blended model. And digital pathology has helped us a lot in setting up a few of these courses, and that helps us to disseminate knowledge a lot more. Next, please. Postgraduate taught programs. Kevin has already mentioned the BSc Cancer Sciences, which has got an integrated MSc component if anyone wants to do a 4th year. The two other courses which are important in Nottingham within the School of Medicine where we come from is the MSc in Oncology and the MSc in Stem Cells and Regenerative Medicine. And these can accommodate both clinicians as well as biomedical scientists. So next slide, please. So there is a lot of cross-talk and cross-fertilization where people learn from each other. So they learn each other's language and a bit of glimpse into each other's world, so that when they go into that collaborative phase in later years, there's already that understanding that is built up. And it is a combination of taught modules and electives. In this MSc Oncology course, for example, the oncologists, they prepare for competencies for the FRCR exam. That's a clinical radiotherapy exam, which the college holds, and some of the modules, they actually teach them about some compulsory, some cancer biology, some radiation physics and radiation biology, which is embedded into that program itself. Whereas scientists, they look about basic clinical concepts and targeted therapies and chemotherapies and radiation therapies, how they work, so they get a glimpse of that. And of course, there's a 120 credit research dissertation. So it is how the programs are built to support both the clinical as well as the research component, which is the main drive for these postgraduate taught programs. Next, please. We had another course which we started, which took a bit of backseat because of the COVID, but we gained a lot of experience from that, which was the MRes in molecular pathology, bioinformatics, and diagnostics, which Prof. Elias and myself, we used to run. And that was so much of an eye-opener, especially during the COVID times, because we had a unique concept of delivering all of the taught component in 3 months online, yes? And everything of that, the examination, the formative assessments, the summative assessments were all online. There was an online poster club, journal club, Viva, so everything was online. During the research component, yes, they could either stay in their own labs and get supervised by us, or they could come to Nottingham to be supervised in one of our own labs. So that shows us the potentials, and it may also show how we can build on international collaborations in sort of research fields where we can have shared supervision between universities. Next, please. We collaborate with learned societies such as the PAC Society of Great Britain and Ireland, and we contribute to the Education Subcommittee and Meeting Subcommittee. And also in terms of clinical trials, for example, I'm part of the Clinical Trials Pathology Advisory Group. So we feed into the clinical trials scenario as well. Next, please. And in terms of national education, the move towards is about training in education. And this is from the PAC Society webpage, which I would strongly advise you to have a look at, because it got grant lectures and awards. It's got online teaching and learning workshops, which we hold, looking at strange topics like social media and teaching. Workshops on developing how to develop a problem-based learning scenario. How can you get the basic IT skills to teach online? So these sort of things are coming more and more into medical education. Next, please. So that's where I'll conclude, and I hope I've given you some directions how the different courses can evolve in undergraduate and in postgraduate medical programs. Thank you.
Thank you, Prof. Abik. I agree with you because nowadays definitely we need find ways for innovative teaching because some people just go to YouTube and act like they are doctors. So definitely need to be more complicated than them. The next speaker is Prof. Shilaj Raman. She is a co-director of Cancer Science. She's going to talk about how to execute ideas, especially into research. Here we have students, graduate students, so pay attention to what Dr. Jayaraman says to talk, because it's very important. You can have a good idea, but if you cannot execute it, that will be a problem. Prof. Jayaraman, please.
Jakarta 2022 Job 1 Research Johnson.
Hello, everybody. It's a great pleasure for me to be able to speak in front of you today. I've been tasked with talking to you about moving from basic science towards translation, and that's what I'm going to try to do today. Next slide, please. So Kevin showed you this slide before. I think there's a basic understanding or a fundamental understanding that there is a bit of a research progression route, that you start with fundamental research, you progress towards applied research, and then you move on towards clinical research with the idea that you're going to make products of some sort that are going to reduce incidence, or they're going to enable better diagnosis or improve patient care in some way. And then hopefully they're also going to be of economic benefit. So that's the normal research progression route that we all think about. But of course, it's not really that linear. Obviously, when you go into applied research, your applied research can feed back into new questions in fundamental research, and your clinical research can also inform your applied research and your fundamental research. So it's really not as linear as it appears. In my case, I work in the area of cancer biology. So I do a lot of cell and molecular biology and genomics and transcriptomics. And I also deal with patient samples because we are interested in identifying new biomarkers for cancer. And we're trying to get some of those biomarkers transferred through to clinical trial. But how, in general, does a fundamental researcher move their ideas into translation? Well, what I'm going to say is I don't think there's any one way to do this. I think there are just multiple routes. But what I think is important is having a very good research development around you and good research infrastructure around you. And in this panel here, what I've tried to show is all of the different aspects that have to come together to allow basic or fundamental scientists with great ideas. You might come up with a great idea, but you can't do it in isolation. So you need to work with other people, and you need to be able to get great data collection. You need to be able to have good tissue access. You need, of course, a well-supported lab with good basic infrastructure for the lab. But you also need to be able to have great seminar programs in your research institute, so you know what is cutting edge science, what's going on around you. You need workshops so you can speak to other people in the same discipline. And you also need interdisciplinary sandpits so you can talk to people from other disciplines, because it's new ideas that feed new translational approaches. And of course, what's very important is having good information sharing, and ideally being able to also deal with industry and engage with industry and engage with drug development as companies and have good technology transfer. So it's really having all of that available to you that allows a great idea that you have to become translated. Okay, next slide, please. So on the basis that I don't think there's any one specific approach, what I thought I would do is tell you about a few examples, just 2 or 3 examples of people who have undergone this journey and are at different stages in that journey from fundamental science to a product and into translation. And then once I've done that, I'm going to tell you just a little bit about my own work. Okay. Of course, the real experts in translating fundamental science to a project, of course, are with us. Lach and Shashanti, Professor Elias and Dr. Shashanti have actually done that. So they're really the people you want to speak to. But I'm going to tell you a little bit about what's going on at Nottingham. Previous slide, please. Okay, so I'll tell you just briefly about Professor Lindy Durand. She is a basic scientist in immune biology, and her interest is in eradicating tumors with personalized cancer vaccines. And she has actually gone through this whole process. Her work was in trying to understand rheumatoid arthritis. That's where she started from. And she was trying to understand, well, why do the immune cells become activated in immune arthritis and start attacking the chondrocytes? So she understood that specific peptides get upregulated in those in that particular disease, and that there was a stressful situation for the cells. Those peptides become upregulated, and so she thought to herself, I wonder if cancer cells are also stressed in a similar fashion, and they also undergo stresses in their rapid transformation and proliferation. And so she looked in cancer cells, in melanoma cancer cells, and she found that many of the same peptides are also present in the cancer cells. But she then went to understand the mechanism as to why aren't cancer cells wiped out by the immune system? Why are those peptides not being presented properly? And so I won't go into the details of the mechanism. If anybody's interested, I'm happy to discuss it in a minute after we've talked. But what she decided to do was investigate that mechanism, and she then started to use those peptides as immunogens. And what she has been able to do, and she calls them moditopes, so they're new peptides that can be presented on the surface of the cancer cells and activate the immune system. When you inject mice with bearing those tumors with these particular epitopes, you're able to clear the tumor, which is really very exciting. That is, an established tumor gets cleared once you've been injected with these epitopes. And because of being able to see such amazing results, where she's seeing 100% survival rate with these particular tumors, she has gone on to take these findings into phase 1 and phase 2 clinical trials. And in addition, she's also set up a company to produce those epitopes for immunization. So she's gone the whole range from having these fundamental, understanding something in a lot of detail, but then translating it into a different scenario, a different area entirely. And I think that is often the approach we need. We need to go from understanding one mechanism and then taking it into a different sphere. Okay, so next slide, please. I'd also like to tell you a little bit about another researcher who I work with a bit, who is doing some exciting work in understanding bioelectronic treatments for cancer. So it turns out that it's not just neuronal cells, but almost all cells have bioelectrical activity. And Dr. Frankie Rawson is very interested in understanding what is the nature of the bioelectrical activity of cancer cells and how it can be distinguished from normal cells. But what he's gone on to do is also to interact with companies that produce electric field equipment. And what they do is they generate tumor electric fields whereby the electric fields can be applied in a localized way to treat cancer cells, because it turns out that cancer cells are very sensitive to localized electric fields. And in fact, this type of therapy is used to treat gliomas, which are very hard to treat cancers because they're located within the brain, of course. And the treatments that are offered, the chemotherapies, are often themselves highly toxic and produce so many side effects. And so these tumor electric fields have been used very successfully to treat these particular gliomas with fewer side effects than the current chemotherapies. So this kind of approach is being developed at the University of Nottingham. And yes, Dr. Frankie Rawson is working with pharma basically to bring this on. With the next slide, please. Okay, a third person who I'm just going to tell you quickly about their work is the work of Professor Angela Sadden. And she actually is an engineer. She's in the Faculty of Engineering. And what she does is try and understand the mid-infrared spectra of the electromagnetic spectrum. And what she has found and been able to show is that the mid-infrared spectrum is really good for being able to identify cancer cells from normal cells. And she's able to show this very well in tissue biopsies. But what she wants to do is not just show this in a tissue biopsy where you can tell it from using many other approaches. What she would like to do is be able to take the mid-infrared spectrum and use it to make a novel kind of endoscope, so that you can put the endoscope within a person and be able to detect cancers in a much earlier and more accurately than the current fiber-optic endoscopes that are used. So again, this is an example of starting in one area of science and moving into another sphere. And I think that's really what I would say is key for translation, thinking a bit laterally and moving slightly from where you're in to another area where it can be applied. So now I'm going to, next slide, please. I'm going to tell you a little bit about my own work. So I work on a transcription factor, and it's known as PRH, or it's sometimes known as HX. And this transcription factor is really important for regulating cell proliferation and also cell migration and cell invasion. And I've been looking at this particular factor in a variety of different tumor contexts. And the thing that is important about this protein is that it tends to, in many different cancers, it tends to turn off proliferation and it turns off migration. And I've spent some years trying to understand how does it regulate proliferation and migration. And we know that a lot of that occurs through its ability to regulate the expression of genes encoding growth factors, encoding growth factor receptors, etc. I don't want to go into all the details of all that, but I just wanted to say that we also know, and we've spent some years trying to understand the mechanism by which it is regulated in turn. And we've discovered that it's regulated by a kinase known as protein kinase CK2. And what I would like you to remember is that PRH turns off the proliferation of many cell types. So it blocks their proliferation, whereas CK2 which is upstream of PRH, turns off PRH. So if CK2 becomes high, then the PRH can't work, and then the cells will proliferate really fast. Okay, so you want high levels of PRH and you want low levels of CK2. So that is, in a nutshell, what my work has been about for a number of years. But we then were investigating PRH in tumor cells, but we wondered what would happen if, in terms of its ability to regulate vascular cells. And we decided that we would look in the vascular space, in the cardiovascular system. Next slide, please. Because there is a disease known as vein restenosis, which occurs very frequently after coronary artery bypass. So when people get angina or a coronary heart attack, they need to have a bypass surgery, and that's a common problem worldwide. But what happens, and then the surgery can be successful, the patient recovers, but what happens after the patient recovers is that the veins become occluded, so the bypass surgery fails. So it's really important to be able to find some way to prevent that bypass surgery from failing. We wondered whether the mechanisms that we had identified to work within the cancer sphere could be applicable to this disease, where the disease arises because those cells inside the artery here, these cells here, start to over-proliferate, and they form this thing called the neointimer. So they overgrow and they also move when they shouldn't move. So we wondered whether the pre-RH protein could block that proliferation, and whether, you know, CK2 was preventing that ability of PRH to block the proliferation. So we investigated that with the help of Professor Sarah George at the University of Bristol and Professor Kevin Gaston at the University of Nottingham. Next slide, please. So I'm going to cut a very long story extremely short by saying that we took inhibitors of that kinase and carried out an ex vivo experiment using human saphenous vein. So that's vein taken from a patient, excess coronary bypass, the veins from the patient were used and placed ex vivo, and then we took an inhibitor for CK2 and looked to see what happened to the neointimer. And what happens is, if you treat it with this inhibitor, the intimer that normally forms, the overgrowing vascular smooth muscle cells, stop growing and have much reduced vein occlusion. And we just checked that PRH was involved because we're quite interested. Could you please go to the next slide? And we could see that when we treat with the inhibitor, we have high levels of the PRH protein. And when we do some sort of blotting, you can see there's less of the phosphorylated form, higher amounts of the normal form. So by using this drug against CK2, we are able to block this intimal thickening. So this is where we're at. We're also moving this now into animal models, in vivo models, where we are seeing very similar effects as what we've seen in these ex vivo models of vein occlusion. And we would like to translate this work further, and we're talking, sorry, next slide, with our collaborators to carry out these animal models and then maybe take it further into clinical trial. So just to summarize, what I've shown you is that if you take an inhibitor and block this upstream kinase, that allows more of the protein of interest to be present, and that protein blocks the smooth muscle cells from occluding the vein. So what I'm trying to tell you is that I feel that by moving my ideas and the information that we got from one scenario into another scenario, this is allowing us to utilize our findings towards a translational outcome. So I would say that that's something that probably everybody can sort of emulate in the future. So next slide, please. So I think what I would say is the most important thing is thinking laterally, making as many collaborations as possible, being very open, and working in an area or an institute which has good research infrastructure. Thank you very much.
Thank you very much, Prof. Raman, for a nice talk about how to think from different problems. Because when she mentioned about the CK2 and also thinking about cell proliferation inhibition by PRH, I was thinking maybe the use is for cancer treatment, but apparently it can be used also to reduce proliferation of the nail intima because there's problem for patients after bypass. So I was even thinking to quiz my students if they pay attention, is it acting like tumor suppressor gene or oncogene? Just to check whether you guys paying attention. All right, last but not least, of course, Prof. Mohamed Elias. He is trained as a pathologist, and he's going to talk something about, it's always picked me, you know. He's going to talk about digital pathology, and he's a pathologist. What's in it for him to develop this digital pathology? Because at the end of the day, people think that maybe you don't need pathologists anymore, just scan the slide, and then obviously the computer is going to tell us what kind of tissue it is. But let's listen to Prof. Elias about the new approach in studying pathology. Prof. Elias.
Okay, thank you very much, Ahmed. Whilst we're loading my slides, which I think have disappeared, so that's one of the problems with digital pathology, just everything disappears. Oh no, it's there. Okay, so firstly, it's great to be back in Indonesia. It's great to be back at Yasi University, and I would like to thank Professor Fasli very much for at such short notice inviting us and so letting us come and talk to you a little bit about some of our work. And you see, we've got a bigger delegation coming this time than before. I'd also like to thank Ahmed. Ahmed is an old friend. In fact, I think of Ahmed more as my brother than anything else now. I can't tell you whether he's an older brother or a younger brother, but I'll let you decide for yourself. Right. And then, I've been working with Santi for about 8 years, and after a number of years, you get to know each other. And so she's deliberately given me this awkward title, about image analysis in digital pathology. So first of all, is it self-destructive? Well, I'm going to try and give you a lot of the problems, so it's not self-destructive yet. And then the other was the other thing that I haven't put up there was, what are the main challenges in developing countries? And I'm not really going to address that, because the main challenge in developing countries is lack of money. So if you have enough money, then you get it sorted. So I'll talk about image analysis in digital pathology, also digital pathology including image analysis. Now, I've got another problem here, because all of my slides are animated, and I'm just wondering, is there any way I can control the slides myself? Because otherwise all you will hear is me saying next, 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 next. I could bring this forward, actually, if that helps. Brilliant. That's much better. I like to cause problems when I can. Yeah. I'll just try and work it from there. Okay, so I'll first of all. This kind of thing. Oh. Do you want to sit down or stand up? No, I'm happy standing up. Oh, okay. It's not a problem with age. It's just that I need to be able to move things along. You'll see every single line is animated, and so that would be the problem. Okay, so let me tell you about the good old days in pathology. So pathology is about extracting data from tissue samples, right? So we extract the data, and then from that data, we try to sort of give some clinical interpretation to then sort of help manage the patient. So this is what I call the data pathway. It goes from tissue, extraction of data, to management of the patient. Now, in the good old days, when I was a younger and happy person, we would have our tissue biopsies. Then we would take the tissue biopsies and we would look at the morphology. It comes to me, I look down the microscope, I make my diagnosis, and then I send the diagnosis off to the clinicians, it's integrated, and then all the management is done. And so in the good old days, I could come at 9 o'clock, by 10 o'clock, I'd be finished, and then I would go home. However, thanks to technical developments, the data pathway has now changed completely. So we still start with the tissue, but rather than having the old morphology, now we've got lots of other things to do because we can interrogate tissue in different ways now. So we can interrogate the genome of the tissue, so we can look at mutation profiling. We can interrogate the transcriptome, so we can then look at expression profiling. We can look at the immunohistochemistry, so a little bit of proteomics there. Then there are lots of other methods emerging, such as metabolomics and things like that. There's so many methods emerging, actually. I'm now thinking of retiring because it's so complicated. And then within that, you'll see there is a digital profile. So now, in pathology, the data pathway is a lot more complicated because we have all of these different methods of data extraction, which then need further integration and then putting into a clinical context of some sort. So that's the data pathway now. And then I'll talk about digital pathology and digital profiling. Now, digital pathology has become quite a popular thing because it seems to have sort of revolutionized pathology in the way that we manage our work and in the way that it promises things that we couldn't do before. Sorry, I'm just going to wreck this now and bring it up here. Oops. Okay. So digital pathology is promising a change in the digital pathology. I'm going to divide it into two parts. One is the digital infrastructure, which is related to diagnostic work, and then the other is related to the computational image analysis. So they're two slightly different streams, but they do overlap with each other. So what's digital pathology promising in terms of for our management of work? Well, it's promising to improve the workflow because it's going to improve work distribution, increase turnaround time. You'll get fewer specimen errors because of the overlap between the pathologists, the ability to share images and improve diagnoses, and then it's going to improve tracing and retrieving of slides. So everything becomes much quicker and much better. And also, Big mentioned the training aspect, so it's going to also improve training. Through all of these things, it's going to improve reporting because it'll allow rapid second opinions. You can measure tumor areas to the margin much more quickly and much more accurately. It's going to allow automated quantification, such as tumor cell numbers, biomarkers, and then it provides this decision support. Now, the decision support is where the computational image analysis comes in, because computational image analysis theoretically could give you a preliminary diagnosis. Now, this is where Ahmed was saying, if the computer is going to make your diagnosis for you, what is the point of me? Well, the point of me is then I just click a button, then I stay at home. I don't need to come to work anymore. So it will provide preliminary diagnosis, potentially give you a diagnostic confirmation. It'll rapidly quantify your biomarkers, and then you're not relying on the pathologist to test by eye what's the level of Ki67 or something like that is. It'll allow molecular analysis, or what I call pseudo-molecular analysis, because sometimes people now claim that you can identify KRAS mutations, BRAF mutations, microsatellite instability, through just the analysis of the images. You don't need to do PCR, you don't need to do any sequencing. Just by analyzing the images, you can get information on these data. And if that is the case, it's going to transform everything. And then also, because we're still discovering new things, we'll perhaps discover things that we don't know yet. And all of this will then contribute to the decision support. And so if the promises of digital pathology are fulfilled, everything will just become better for pathology diagnoses, both in terms of what we can do now and also what we will be able to do in the future. So that is great, and that's a big if. So if everything is delivered, everything will be transformed. But the problem is there's a number of obstacles before we get to that delivery. And these obstacles are what I'm going to talk about in the next few minutes or so. So the obstacles lie at the pre-analytical stage, which is the way that tissue is handled and the way that the image is acquired. They also lie at the analytical stage, the way that the tissue image is interrogated. And then also in the post-analytical stage, in the way that the image is interpreted and integrated into the clinical management pathway. And so what you'll see is that these pitfalls, they're not insurmountable, but they are sort of fairly reasonable sized obstacles, which will, which will keep me in a job for a little while longer. So these are all sources of variation, and this is something that the computers don't handle very well, whereas humans do. Computers don't handle that very well. So I'll just now kind of go through some of these sources of variation, and it's what boils down to understanding how specimens are handled. So what we have in the digital pathology workflow is you have your tissue, or you have your resection, and you have your image. And then from incision, where the surgeon puts in the knife into the patient to get the tissue out, from that point onwards to where you get your image for analysis, there are lots of sources of variation, and these are the confounders that digital pathology is going to have to deal with. So some of the confounders are, for example, when you have, so the patient's on the table and the surgeon's working, you have a fast surgeon who will take the tissue out quickly. You have a slow surgeon who will take the tissue out more slowly. But whilst that operation is happening, the tissue is not static. It will undergo changes. And so that will lead to changes in gene expression. And so if digital pathology is going to quantify gene expression, but the gene expression is going to be influenced by the speed at which the surgeon is operating, you can see that that's going to be a potential confounder. Once the specimen comes to us in histopathology, then we put the specimen into a fixative, such as formalin. Now, formalin causes cross-linking of molecules, cross-linking of proteins, cross-linking of DNA. And so the amount of time a tissue spends in the formalin can influence the level of fixation. That level of fixation and cross-linking then affects your downstream activities. And so again, you can see that if the mutation profile is being changed by artifacts by the formalin, any test which claims to do molecular analysis is going to potentially have issues separating those artifacts. And this is just an example of how fixation can affect your image analysis. So we've got immunochemistry here. This is the same tumor. One's a biopsy on the left, and the other one is the resection on the right. So the biopsy has spent about 2 days in formalin. The resection specimen has spent 2 days in formalin as well. But the difference is the biopsy is a tiny thing. And so the formalin goes in, fixes the tissue, and you get the nice brown staining indicating that there's a presence of MLH1 protein there. The resection specimen is a big thing. It spends 2 days in formalin, but it doesn't get fixed completely. And so because it doesn't get fixed completely, the proteins are, are affected. And there on the right-hand side, you can see that MLH1 is barely visible. So on the left-hand side, you've got a true diagnosis. And on the right-hand side, you've got the same patient, the same tumor, but the diagnosis is different because of the way that the fixation has affected the downstream tests. Once we've got our tissue fixed, then we cut sections, and so the cutting of the sections may cause some problems. And then once we've got the sections cut, then we need to scan the images. Now you think, okay, well, that's surely there can't be any problem with scanning images, but they can, because there are different types of scanners and they all have their own speeds of scanning. They all have their own strengths and weaknesses. And so when you're doing the image analysis, the actual image you're capturing and analyzing may differ from one scanner to another. And so currently, one of the things that we do know is that you have the same tissue section, and you scan it in with a different scanner. If you run an algorithm, the results you'll get will be different. So same tissue section, different scanner, same algorithm, results are different, and that's just not good enough yet for the patients. So like I said, there's a lot of variation in the speed and the way that they have their images, and they all have different formats in which they store the images as well. And this can all, so basically influence the image analysis algorithms. So here we've got the downstream activities from image acquisition. The data is also compressed because the data files are so large. The data has to be compressed, and then the data has to be recovered after compression. And that in itself can also cause some issues in digital pathology. So the quality of the scan may be variable. You may get variations in focus occurring despite the presence of autofocus. And this is the important thing, that the data varies between the scans, and that can then influence your downstream, the performance of your downstream algorithms. And then there are other things that kind of we as pathologists see, that you can have artifacts such as dust, and you have an image of dust in your scanned image. The computer won't know that that's dust unless it's been extensively trained to identify dust and all kinds of dust. So it's another potential confounder. And also then the images are huge, about 5 gigabytes for each image. And that then just shows that you need a really, really good infrastructure to be able to handle all of these images which occur within a department. And this again is just some examples of the kind of problems that you may have. So on the top, you have a tissue section where the blade cutting the section has become frayed. And so you've got all these big holes in the middle of the section, and that's going to cause some problems. Then at the bottom, you've got the same, you've actually got exactly the same image, but scanned in on kind of 2 different occasions on 2 different scanners. And so this is sometimes the kind of variation that you can get between scanners, and that can affect the way that the data are analyzed. Here's another example of how just subtleties in fixation that you can't see by eye can affect the way that the image analysis is performed. Now, I don't know whether you can see it online. You certainly can't see it on that screen, but I'll just point it out to you. Oops. So, on my screen there, hopefully what you'll be able to see is that this gland here has been segmented by an image analysis algorithm that we have. And what you see is this half has been segmented, and this half has been missed. In fact, you can see it's soft, because this looks a little bit darker than this part here. And the point that I'm making here is that by eye, this looks exactly the same. And if you look at the distance between there and there, it's maybe 20, 30 microns. So, you can't say that there's variation in fixation. So there may be other sources of variation just from there to there, which has resulted in the failure of the program to take out this part of the gland. And that again, just shows that there are complexities within the image analysis. So those are just examples of the complexities that can occur. And then there are some kind of complexities in the sort of post-analytical the post-analytical examination of the tissues. And so again, I've shown here that you've got these papers now published which claim that just from the basic image, you can extract molecular information. And the question then is, you know, when you start going out and you get all these other variations in fixation and all these other variations in, you know, sort of the time of surgery, whether these programs will perform just as well as people are complaining. People are claiming. Okay, so there are kind of variations in the way that the algorithms handle the images, despite all of these publications. So a lot of the a lot of these current publications are all based on deep learning. And so this is one of the other problems that we have is the deep learning, mainly black box approaches. And so what you know is that, you know, you feed the images in, eventually the algorithm will be able to extract different features and discriminate between two different samples, but you don't know what those features are and how it's how that discrimination is based. And so one of the problems is that the black box applications result in a failure in us, in the pathologists, to be able to control the way the images are being analyzed. And then there's also sort of issues around generalizability, about transfer learning, whether you can sort of transfer algorithms from one tissue type to another. I mean, you can't even transfer them from one scanner type to another. So these are other kind of obstacles that there are, that are waiting to be resolved. And then there's issues around interpretation, so whether the image analysis is overseeing or sort of seeing things that human beings wouldn't see, and whether those are artifacts that it's pulling out rather than true effects. And then there's other issues like that. So I've got an example here. Again, I know this isn't going to show, but this is just to demonstrate the effect of context. So we've got one slide here, and I've got that there and that there. So these are the same sentences. And you can see the one at the bottom is much brighter than the one at the top. But of course, it's not much brighter. You know this is a trick. It's exactly the same sentence, but you can see that there's a difference in the way that we see it as humans because of these surrounding environments. So that's the context. Now, a lot of pathology is based on interpretation and context. And the question then is, will the algorithms be able to discriminate in the same way? So interpretation of histology is absolutely based on context. So it's not sort of based on, kind of just one bit of information. And the analytical steps involve, sort of the clinical information, low power review, high power review, and then supplementary tests if necessary. And then the post-analytical step is integrating all of these different bits of information. And so the question is, is there any way that we can get computers to sort of do analysis like human beings? And so this is, so kind of one potential route. So we're looking at biopsies, for example, in the colon. And as humans, we'd then sort of take the biopsy, we'd look at the clinical data, and then we'd sort of go through high power, low power review, etc. So in order to try to get the machines to analyze like human beings, if that's the answer, I mean, I don't know, but if that's one answer, then here's a route that we can probably follow. So if the clinical data indicates probably normal, i.e. the clinician hasn't seen anything, then you need natural language processing algorithms to extract that clinical information to then feed the downstream tests, which would be the feature extraction, so normal. And then if the feature extraction shows not normal, then it goes down the other algorithm. But the important thing is then to try to take each step and then maybe get the machines acting like human beings. Then eventually, Ahmed will be right. Then I'll be out of a job. So the challenges of digital pathology are that digital pathology has great promise, but the issues include the image quality, especially the image quality for the computational image analysis. It's so important. For diagnosis, it's less important. You obviously need a certain level of image quality for diagnosis, but it just has to be enough. Whereas for the image analysis, it has got to be, maximum image quality. Then you have other issues such as network speed, because the images are so big, they need to be compressed and then decompressed. then you've got the whole issue about validation of algorithms. So you can have an algorithm which will then get approved for, let's say, making a diagnosis of cancer. Once you change that algorithm once you improve that algorithm, the fact that you changed it then currently means it has to undergo the revalidation process all over again. So every single change then sort of becomes problematic. And then we've got to the issue of, so just how useful the information is going to be. So if you can detect, for example, if you can detect KRAS mutations, so by image analysis, but it's only in 80% of cases that it's accurate. In 20% of cases, it's giving false negatives. Just how useful is that? Are we going to be able to do anything with that? Oops. So we're almost there, but we're not quite there. And so, the take-home message is that digital pathology is absolutely fantastic, and I'm a big fan, despite all my negative comments here. But these are challenges which can be overcome, and so the challenges are pre-analytical in the processing of the tissue and the way that the image is acquired. The challenges are analytical in the way that the image is actually interrogated. And then the challenges are post-analytical in terms of getting so your results from the interrogation and integrating it into a clinical pathway, which is robust and which is successful. And so the very, very final point is that, at the end of the day, it's the sources of variation which cause problems for digital pathology, basically. Okay, I hope that was interesting. Thank you.
Thank you, Prof. Elias, for a nice talk. So obviously, pathology will be around. Okay.
Sorry.
After that, I don't care. Okay, all right. Thank you so much for the insight. Okay, so we have a challenge today because it's closer to Maghrib. So I think we probably have a very limited opportunity for QA. Okay. So let's see, we probably have time for one question from the audience and probably another one from the so anybody? First question. Oh,
yeah. Thank you. I'd like to ask in terms of the design that, sometimes we would like to stay in the basic science, more publications, opus, Q1, etc. But when you move to translational research, you have a different environment, ecosystem. How do you get some incentive to move from basic to translational research? Thank you.
What's the incentive to move into that?
Yeah.
What is the incentive to move into applied research, you're asking? Well, I mean, I think it's immensely exciting to move from basic research into applied research, because although you are usually focused in your own area and very interested, the idea that some mechanisms that you understand or some insight that you've had can be of utility is itself a massive driver. And in terms of how to go about doing that, I would say that it really is from the fact that you have these type of discussions. Workshops often are a major help for allowing the movement of the ideas and the generation of the excitement to come from one to another. I think it's the ability of researchers to sit together and discuss it. That is the thing that really drives you to think, okay, so you have the model, I have the idea, why don't we come together? Why don't we just see what happens? And it's that excitement of seeing what happens is true, whether you're in applied research or basic, whatever, clinical research, everybody's driven by that curiosity to see, and so I think that's translatable across.
Do you find the limitation of the
publication to accept your transnational research comparing to the number of publications ready to accept the basic research?
No, I don't think so. I think that there is room for, rigorous science, whether it's in applied or in fundamental research. I think it's not that there are fewer publications that will take the worth or anything like that. I think we haven't had particular difficulty trying to explain our system or publish in this new area, no more than when we publish in normal fundamental research. So I don't think that's an issue.
Right. Prof.
Sorry, if I can do a follow-up question to Professor Fassi's question, both to Sheila and Kevin, is so when it comes to the kind of publications versus protecting IP, how do you think the balance should be managed? So if you come across a discovery which is sort of potentially game-changing, it could lead to a product which will then sort of go on and affect a lot of people. Yet at the same time, it's a competitive market, and you don't want so your competitors getting an angle on that. So you need to sort of kind of protect it and let's say sort of file it for patents. But then once it's being filed, then you can't publish. But whilst you can't publish, then it's affecting your grant, your grant getting abilities. So have you any thoughts as to what you should do when when you've got something exciting which you want to protect, but you also want to tell the world about it? How do you balance those two different things?
Well, I mean, you do, I think, you go and investigate, you go and talk to your technology transfer office, you discuss with them, but it is very difficult. It's not an easy balance, and it's not an easy...
That's why I asked you the question. Yeah, I was hoping you were going to tell me the answer.
In our case, we did go to technology transfer, we did discuss with them, and in the end, we published first,
right?
Because it took a long time for the university and for other people to become interested. So we published the data before we had protected it. But I mean, that may or may not be the best route to go down. I don't know if you've got something to add.
Can I add that? My experience with patents is a bit different from Sheila's experience because she's talking about a different system. But in the patents that I've written in my work, I haven't found it to be a very long process because I think writing patents is much quicker than writing papers. So,
okay.
I haven't written that many though. I've only written 4. But
four's pretty good.
I found that to be a fairly quick process, and then once the initial filing is made, then you can start working on the publication. So my thoughts are always, if it needs to be patented, get the patent application.
So your is protect first, publish later.
If there's a possibility of commercial exploitation, I think it's really important, yes, to protect as much as you can. But the trouble is, I think a lot of universities don't have enough money to pay for all of the patents that are going to be created. So a second problem is getting the patents to be financed. In my case, for the patents that I've written, they were all financed by industry, not by my university. So,
So that is interesting.
If the deepest pockets, the patents that I filed cost £250,000 in patent costs, and that was all paid by industry, not by the university.
Right. Okay.
If you wait for the university, you'll wait forever.
So if I can ask a cheeky question to Professor Fassi now. So let's say Ahmed came across something brilliant, and he said, I want to, this is going to change the whole of Indonesian medicine, but it's highly secret. Will you say to him, protect it first, then publish, or would you say to him, go ahead and publish and tell the world?
I don't know, maybe Raman can answer. Well, from our point of view, because right now in Indonesia, publication is the highest reward.
Right.
So sometimes we forget about patent as far as we can publish.
Right.
And then down the road, we realize this is we miss something because not being protected. But then if the researcher related to industry, they are really care on patent. They go for patent first, and then after getting that, then do publication.
Thank you, Prof. Asli. Thank you, Prof. Elias. Thank you for the guests, Dr. Raman, Dr. Gaston, and Dr. Abik. Unfortunately, time is for Maghrib now. So we have to get ready for Maghrib. But before that, just before we close the, we can close it now. We're going to have exchange of souvenirs, Prof. Asli, Prof. Elias. So please, our guests to be up. Oh, okay. There's a presentation from Prof. Elias. All right, to Prof. Asli.
Because Professor Pasti is a friend of mine, and so I've taken the decision to do this myself. And so, again, just to say that, so we're here with the whole aim of developing collaborations, so we are really looking forward to working with people, and it's really great that again you've been so kind inviting us here, and just as a small gift, just as a small gift, we'd like to present you with this from the University of Nottingham. So thank you very much. It's very kind.
Thank you, Prof. Elias. Thank you.
Small contact from Gaston.
All right.
Just to remind you, they are close.
All right. Thank you very much.
Yeah. Yeah. Sarah. That's small contact.
Very
Thank you.
Very much enjoyed it.
Thank you. So good luck with your bachelor degree on microbiology. Yeah.
Okay.
Yeah. Naturally. Yeah. Thank you. Yeah. Yes. Coba-cobanya ya. Tunggunya teruslah jadi bagian dari kita ya. Yeah, thank you,
Yeah, thank you, Prof. Asli. Thank you for everybody. And I guess time is come that we have to wrap it up to the end. And thank you for. Okay. And let's take a picture. Berdiri. Yeah. Okay. Good morning. Prof. Rika, monggo, Prof. Prof. Tak, monggo. Pasek, monggo, silakan.
Nanti mahasiswa kalau mau bawa aja kursi ke depan ya. Cukup kursinya.
Cukup, bisa.
And also Ahmed as well.
Oh. Oh, mana?
Sini.
Oh, sini. Oh, pada teman. Jangan.
One, two, three. Okay, smile. One. Nah, mahasiswa dengan beliau-beliau nih. Mari. Nanti membaca apa bapaknya aja baca artikel sekarang ada fotonya.
Ada foto. Dengan
Biar yang mereka aja. Ya. Bisa silakan dengan tamu kita.
Prof ikut dong, Prof.
Hah?
Pas misalnya kapan lagi ya Pak?
Oh, iya.